Good morning, students. We are slowly progressing towards the various conditions that affect the larynx. I think last class I was telling you about the functions of the larynx, and I told you that the functions of the larynx, the most important function is the protection to the lower respiratory tract. That is the most important function. And apart from the other functions are the phonation, fixation of the chest, and the voice production. That's why, though basically it is called as the voice box, the primary function is, I'm just repeating again, protection of the lower respiratory tract from the either the food, water, saliva going into the respiratory tract, which can lead to severe complications and sometimes which can lead to death. Now, the vocal cords are the third line of defense for a procedure, for this procedure. The first line, there are three levels that are described, and the three levels are, first one is the aryepiglottic folds. They close the aperture, laryngeal aperture, which is opening into the laryngopharynx. The second one is the false vocal cords, which are otherwise called the vestibular folds. And the third one is the true vocal cords, which are very powerful valves which close the glottis, that is the passage, very strongly. So out of these three, vocal cords are the strongest one, which prevent the food or air, the water or the saliva entering into the lower respiratory tract. So with this we have also dealt, I think last class, the various infections that affect the vocal cords. Today we will deal with an important function, that is the vocal cord paralysis. This topic is important because as a ENT surgeon, we see this vocal cord paralysis happening or being seen quite frequently. And so this vocal cord paralysis is a common problem, as I told you, and it's a sign of a disease and not a diagnosis. Something like if you have fever, fever is not a diagnosis. Fever is caused by some kind of a infection, either a bacterial infection, a viral infection, or fungal infection, classified into acute and chronic. So fever is only a symptom. So similarly, vocal cord paralysis is not a diagnosis of a disease. It is only a kind of a symptom which presents in several ways, which we will discuss. So that is what we need to understand today. So it is not a disease proper. And with this small introduction, we'll go into the anatomy of the larynx, which has been extensively discussed earlier, how the laryngeal inlet opens into the hypopharynx, which is a common passage for the food and air, where it divides into posteriorly into the food passage, that is the esophagus, and anteriorly into the larynx. And we have seen during deglutition how the larynx protects itself by coming a little bit forwards, lifting itself up, and closure of these three valves, the areoepiglotic fold, the false vocal cord, and the true vocal cords, and how the food is propelled into the esophagus. Now, this if you see the process of deglutition, the first phase, that is the chewing, is the voluntary phase. Rest of them are involuntary, they just happen, and these are controlled by certain nerves which act on the muscles and then produce a kind of a coordination and propel the food from the oropharynx right into the esophagus. Now, the important nerve that we are going to deal with today is the vagus nerve. Vagus nerve is a nerve which has got three nuclei. One is the nucleus ambiguous, which in here is the red one. That is the nucleus ambiguous, and the green one, that is the dorsal nucleus, and the third one is the tractus solitarius. And these nuclei are situated in the medulla oblongata. This medulla oblongata is otherwise called bulb. Sometimes you hear the nomenclature like bulbar paralysis. That means these are the nerves which are affected. Bulb is nothing but the medulla oblongata. Now, so these three nuclei of the vagus, the nucleus ambiguous, which is the red one, that is the one which is the motor, that is the motor center for the various muscles that are innervated by it, whereas the dorsal nucleus is the one which carries the efferents of the parasympathetic fibers. The parasympathetic fibers to various organs which supply the smooth muscles of the bronchi, the larynx, the esophagus, the heart, the stomach, and the intestine, small intestine, sometimes that spreads up to the large intestine, part of the large intestines also. So that is the dorsal nucleus, the parasympathetic fibers. And the third one, as we said, is the tractus solitarius nucleus, which is an afferent. That means it receives the sensations from the pharynx and the larynx and the esophagus. So it's a sensory one. So these are the three nuclei which you should basically understand, which are situated in the medulla oblongata. The nucleus ambiguous is the voluntary muscles, starting from the palatal, the pharyngeal, and also the laryngeal muscles. Then the dorsal nucleus is the parasympathetic outflow, and the sensory, the tractus solitarius, is the sensory from the pharynx, larynx, and the esophagus. So these three nuclei you must remember, and from there the nerve emerges out. It travels in the intracranium, and then it comes up to the jugular foramina. The jugular foramina. From there it comes out into the neck from the jugular foramina, wherein you have the other associated nerves, the ninth, the glossopharyngeal. This the 10th the vagus, and the 11th the accessory. All of them, they come out through this jugular foramina along with the interjugular vein, and then they travel in the carotid canal, carotid sheath, along with the carotid artery and the jugular vein, and its relation is posterior lateral. It travels in that, and then from the neck, it goes down into the thorax, and a nerve which is called the recurrent laryngeal nerve. Recurrent laryngeal nerve is the one which hooks round on the left side the arch of the aorta, and on the left side, on the right side, hooks around the subclavian. I'll show you some of the diagrams, maybe you will be able to understand. Basically, you should understand that the nucleus is situated in the medulla oblongata. From there, these three nuclei, and how it travels in the intracranium, and then comes out through the jugular foramina. Before it comes out, the branches that we will discuss, and then it comes into the neck. From there into the thorax, the recurrent laryngeal nerve comes back into the neck again, and then the laryngeal, it supplies the esophagus. Vagus nerve further continues down. As I said, esophagus, the stomach, the intestines, small intestines, a part of the large intestines. They say this is the longest the cranial nerve. Longest cranial nerve. You have 12 cranial nerves. So the 10th nerve, the vagus, is supposed to be the longest cranial nerve. It starts in the neck and then goes right up to the small intestine into the abdomen. Okay, neck, thorax, and into the abdomen. So this is the longest nerve. Now let's see diagrammatically. Let's see how this happens. And as I told you, the nucleus ambiguous supplies all the muscles of the palate, and then the muscles, the constrictor muscles of the pharynx, then the laryngeal muscles, intrinsic muscles of the larynx. That is the motor component. Now the sensory component is by the tractus solitarius. Is that the sensations from the pharynx, the base of the tongue, and also from the sensations from the larynx and the esophagus. So these are the sensations that are carried by these nerves, and then they are delivered to the tractus solitarius and the dorsal nucleus of the vagus. Which is also situated in the medulla oblongata, is the parasympathetic outflow. Okay. Now, before it, in the motor, in the ordinary sensation, there is one nerve which is given off in the intracranium itself, and which supplies the posterior part of the external auditory canal. This nerve is called the Arnold's nerve, because that is the nerve described by Dr. Arnold. The sensory component is at in the external auditory canal deep. Okay, and this is about the nucleus ambiguus, the parasympathetic fibers, and the afferent fibers, sensory fibers from the pharynx, larynx, and the esophagus. Then the vagus exits through the jugular foramina, and then when it exits with the jugular foramina, it is also associated with the 11th and the 9th cranial nerves. Together they come out. And hypoglossal is also closely associated, but it does not come out through the jugular foramina. It comes out through another foramina which is specially made for that, foramen for the hypoglossal, which is very close to that. And all these come to the base of skull, and then how they supply in the neck, that we will see later. So that is basically you should have that understanding. And as I told you, the recurrent laryngeal nerve, that is the vagus nerve, which is coming through that's the carotid artery, the common carotid artery, and then it travels in that sheath along with the jugular vein, which is not represented here, and then comes like that and comes anterior to the arch of the aorta. This is on the left side, and then hooks around the arch of the aorta and comes into the neck again. It comes into the neck again, and it distributes, pierces the crico just behind, it goes into the larynx just behind the cricoarytenoid joint, and then supplies all the muscles, intrinsic muscles of the larynx, except the cricothyroid, which is supplied by the external branch. We'll come to that external branch later. So this is the recurrent laryngeal nerve, which is coming like that, and then hooking around the arch of the aorta on the left side, and comes back into the neck in the tracheoesophageal groove, and its important relation to the thyroid gland and its intimate connection with the inferior thyroid artery is important for us, because the thyroid surgeries, this is the nerve which is likely to be jeopardized or likely to be injured. Then on the right side we have seen same carotid artery, carotid sheath, and then this is the subclavian. This is the common carotid, this is the and it hooks around the subclavian and comes into the deep to the thyroid in the tracheoesophageal groove, and then this is the one which comes a little lateral, so it's likely to be injured. So out of these two recurrent laryngeal nerves which are prone for injury in a thyroid surgery, the chances are more for and supplies the all the intrinsic muscles of the larynx except the cricothyroid, and also the sensory component below the glottis. So that is about the recurrent laryngeal nerve. Now there are three branches of these vagus nerve. The first one is the pharyngeal branch, which supplies the constrictor muscles, stylopharyngeus, and comes down. And then second branch is the superior laryngeal nerve. This is the superior laryngeal nerve, which divides into the internal laryngeal nerve and the external laryngeal nerve. The internal laryngeal nerve pierces the cricothyroid membrane. Pierces the thyroid membrane. Pierces the thyroid membrane. Let me see the diagram with that. Yeah, this is the one. So the superior laryngeal nerve, how it divides into the internal laryngeal nerve. This is the hyoid and that's the thyroid. So it pierces the thyroid membrane and goes into the larynx. It is purely a sensory above the level of the glottis, above the level of the vocal cords. So this is the superior laryngeal nerve internal branch. Whereas the external branch is the one which continues further down and then comes and then supplies this cricothyroid muscle. And this is one of the intrinsic muscles of the larynx, and the function of this cricothyroid muscle is the tensor of the vocal cord and adductor. Adduction means coming together. So that is the superior laryngeal nerve. Then we go to we have seen the recurrent laryngeal nerve and the superior laryngeal nerves. Then we go to the musculature. We have already dealt with this musculature of these, and broadly they can be classified as the abductor and adductor. Abduction means away, moving away from the midline, whereas adduction means coming together. So in the abductors, there is only one single muscle which is an abductor. You should remember this. Posterior cricoarytenoid muscle. That is, as you know, this is the thyroid cartilage, and this is the cricoid cartilage, like a ring, signet ring, and above the lamina of the cricoid, that is the posteriorly, you have this arytenoid, which is sitting on the superior surface of the lamina of this cricoid, and the posterior cricoarytenoid muscle is attached to the muscular process, and when it pulls the cricoarytenoid, when it contracts, there is a kind of a rotation that happens in the arytenoid, which has got a vocal process. So the vocal process is the one to which the vocal cords are attached, and anteriorly they are attached to the posterior surface of the thyroid lamina in the center. So when there is a rotation like that, the vocal cords get abducted. So the chief abductor of the larynx is the posterior cricoarytenoid muscle. It's one muscle. Then we go to the various muscles which adduct. The adduction adductor muscles are the lateral cricoarytenoid. Let me see if I can show the diagram of this. This is the lateral crico. This is the cricoid, and this is the arytenoid. So the posterior cricoarytenoid was like that, and this is the lateral cricoarytenoid. So when this lateral cricoarytenoid muscle contracts, the vocal processes, they come together, and so the vocal cords come together, which action is called the adduction. Now that is as far as the vocal cords are concerned. Then you have the space between these arytenoids, and there is a muscle called transverse arytenoid muscle. This transverse arytenoid muscle is the one which brings both the arytenoids together, and so that gap between the arytenoids is this space is also closed. So the adductors of the vocal cords are, the powerful adductor is the lateral cricoarytenoid muscle, lateral cricoid to the arytenoid, and the other one is the posterior cricoarytenoid, or transverse arytenoid muscle, which brings the arytenoids together. And apart from that, you have the other muscles which are attached from the arytenoids to the posterior surface of the lamina of the thyroid cartilage. These muscles, when they contract, these are the muscles which are thyroarytenoid, from the thyroid cartilage to the arytenoid. These are the muscles, and they usually they are grouped into thyroarytenoid, or the medial most muscle is the one which is called the vocalis muscle. So basically they are all coming from the arytenoid to the thyroid cartilage, and these are they vary the dimension of the vocal cords. They either lengthen or shorten or make the bulk of that vocal cord. So basically the adductors and the abductors are the muscles which are important. Of course, the tensors of the vocal cords are also important in the speech production. Now once again we come back to the functions of the larynx with this brief anatomical understanding, and the protection of the airway is the chief function. The passage, respiration, and the phonation are the secondary functions, and how it stabilizes the thorax in physiological when you are trying to increase the intra-abdominal pressure, like coughing, the weight lifting, and during defecation and during labor. Now, if you go into the pathology, various positions of the vocal cord are being described. One is the medial, that is in the midline. The vocal cord is in the midline. And 1.5 millimeters is the next one, is called the paramedial, and 3.5 millimeters is called the intermediate, which is otherwise called the cadaveric, and the fourth one is the slight abduction and full abduction. Slight abduction and full abduction. These are the positions of the vocal cord that are being described. We will see in various conditions how these positions are important. Now, there are various theories that have been proposed as far as the palsy, the laryngeal palsy or vocal cord palsy are concerned. One is the Simmons law, which says that in the first stage, you have both the abductors and adductors. All of them are supplied by the recurrent, supplied by the vagus nerve. So, when there is a muscle paralysis, suddenly the abductors are the ones which are first affected, and so the vocal cords, because the adductors are very powerful, they go into the midline position. So in the first stage, the abductors are damaged, and the adductors being more powerful than the abductors, the vocal cords, they are in the midline and mobile. In the second stage, you will see there is more damage that has occurred, and the cords are in the midline but immobile. And in the third stage, which is the added paralysis of the cords, go into a phase called the cadaveric phase, or which is otherwise called the intermediate phase. So initially they are in the midline, but as the nerve degeneration occurs, they go into the cadaveric position. And there is another theory that is proposed and well accepted, that is the Wagner and Grossman theory. And this says the complete palsy of recurrent laryngeal nerve, the cord is in the paramedian position, that is in the second position. Okay, midline and the paramedian position. But this is only recurrent laryngeal nerve if it is affected. Now, if it is if the superior laryngeal nerve, which supplies the cricothyroid muscle, that is also paralyzed, then it goes into the intermediate position, or which is called the cadaveric position. So that is about the theories that have been proposed. And when you come into the various sites of lesion, usually the cranial nerves, in the intracranial, from the cerebral cortex to the nuclear region, they are called supranuclear. From the nucleus, that is in the medulla oblongata, and at the nuclear level, lesions of the soft palate, pharynx and larynx occur, because there you have all the three nerves, 9th, 10th, 11th, which I said is the bulb, which is called the bulb. So at the nuclear level, the associated 9th and 11th cranial nerve palsy also occurs. Then you have the posterior fossa, as the nerve travels in the posterior cranial fossa. and ultimately comes out through the jugular foramina. There are certain syndromes that are being attached, and then after the jugular foramina, it comes out into the extracranial region and travels, as we said, along with the internal jugular vein, initially the carotid artery, and then comes down how the recurrent laryngeal nerve is given up, and the vagus nerve per se continues, and the parasympathetic fibers are lying to the smooth muscles of the bronchioles, the heart, the esophagus, the stomach, and the intestines that we have seen. So that is the extracranial part of the vagus nerve. Various causes which produce this are usually they are classified like this: idiopathic, where we don't know the reason; the infectious, various infection conditions, syphilis, tuberculosis, thyroid, the viral infections, and the inflammatory conditions like the rheumatoid arthritis, and then the malignant tumors, either in the intracranium or in the base of skull base, or in the neck, or in the chest. We'll come to that, and the various conditions that are responsible for producing the vocal cord paralysis, and the various malignant conditions. And one of them is very common, the malignancy of the lungs. Then if you go into the surgical, that is the traumatic, either this is mostly the iatrogenics produced by the surgeons, the thyroidectomy during pneumonectomy, and the cardiac bypass surgeries, and sometimes the trauma can be penetrating neck injuries during intubation and whiplash injuries, which are very common in road traffic accidents, and the posterior fossa surgeries, various surgeries where the cranial nerve passes. Now there are various other conditions that are described, like the neurological conditions, the various central nervous system degenerating conditions, like the Wallenberg syndrome, syringomyelia, encephalitis, Parkinson's, the poliomyelitis, multiple sclerosis, myasthenia gravis, Guillain-Barré, and diabetes. These are the various neurodegenerative conditions which can affect, apart from the vagus nerve, the other cranial nerves also. So these are the various inflammatory, traumatic, malignancy, tumors, neoplastic, and neurological. That is how it can be classified. Then you have the intracranial causes. In the intracranial causes, usually the head injuries and the cerebrovascular accidents, and the bulbar poliomyelitis. As I told you, the bulb means the medulla oblongata, where all the 9th, 10th, and 11th cranial nerves are affected. Then, as it comes out through the cranial, in the cranial region, usually the fracture of the base of skull, or jugular foramina lesions like the glomus tumor, the nasopharyngeal carcinomas, and skull base osteomyelitis. These are the conditions where which are called the cranial region, where the 9th, 10th, and 11th cranial nerves are together affected. Then once you come into the neck, you have the various kinds of surgical procedures. Most commonly is the thyroidectomy, and the thyroid tumors as such, when they grow, when they are malignant, they compress on the recurrent laryngeal nerve and cause the vocal cord palsy. And sometimes the postcricoid, because that is the place where it is in close approximation with the in the tracheoesophageal group, and malignant cervical lymph nodes which infiltrate into the nerve and damage the nerve. This is in the neck region. Then we go into the chest region, where involvement of the recurrent laryngeal nerve is either bronchogenic carcinoma, the cardiothoracic surgical procedures, the aortic aneurysm, the mediastinal lymphadenopathy, and esophageal surgeries and tracheal surgeries. So these are the various the conditions which can give rise to a vocal cord palsy related to the chest. So we have seen the intracranial, then we have seen the cranial, that is the jugular foramina, then you have seen the neck, the various corners, then the chest, the cause. Now we try to slowly understand, because we have studied in the neck, it is the superior laryngeal nerve, and which divides into internal laryngeal and external laryngeal, can be paralyzed or traumatized. Then the recurrent laryngeal nerve. These are the two nerves. So let's consider unilateral superior laryngeal nerve. This is the one which supplies, as I told you, the external and internal branches are there, superior laryngeal. And the internal laryngeal is purely sensory. Sensations of the larynx just above the glottis region. So, but the external one is the one which supplies the cricothyroid muscle. Let's go back to that and just for you. See, this is the one. So if there is, this nerve is affected here, or if this nerve is affected here, one side, or if the nerve is affected here, all these three conditions can be easily interpreted. If this is cut, then the laryngeal sensations above the glottis are lost, and also the external laryngeal, the cricothyroid, which is the main tensor of the vocal cord and mild adductor. So we'll see how this affects the larynx. Now, that is as the superior laryngeal nerve injury in conditions. This is what has been described, sensation supraglottic region. And when the sensation is lost, sometimes the mucus or the saliva can trickle without the sensation, and so they have the mucus going into the larynx, and then you have some kind of a throat clearing kind of a gesture that is being done. And loss of motor function, cricothyroid muscle, slight voice change. It is a slight voice change because it is only a tensor of the vocal cord. So this is particularly important for the people who are like singers, the teachers. So otherwise, as far as generally the patient does not complain of anything, his speech is almost normal, unless he sings, his speech looks as almost near normal. So not much of a affection as far as the voice is concerned, as I told you, except for the singers and the professional who are involved in the teaching, that is the teachers. Then that is about the superior laryngeal nerve. Then the recurrent laryngeal nerve. The recurrent laryngeal nerve, on the right side and left side we have seen how it hooks around the arch of aorta on the left side, how it hooks around the arch of the aorta on the left side, and how it hooks around the subclavian on the right side. Be affected in various conditions related to the neck or sometimes the thorax. So usually when the recurrent laryngeal nerve is damaged, all the intrinsic muscles are supplied by the recurrent laryngeal nerve, except the cricothyroid muscle. Cricothyroid muscle, as we said, is the tensor of the vocal cord. At the same time, mild adduction. So the recurrent laryngeal nerve, initially when there is an injury, it goes into initially the adduction. Okay, it goes into the adduction caused by the vocal, assume the paramedian position. Okay, the voice is breathing, but compensation slowly occurs. This is the cord which is paralyzed, which is not moving. Mild adduction is still preserved, and the tension of the vocal cord, tensor of the vocal cord, is the cricothyroid. So slight amount of function remains there, but the other vocal cord slowly tries to compensate and close this small gap. This may take about 6 months time. So the breathing exercises, the voice speech therapy can be advocated during this time. So recurrent laryngeal nerve, the treatment is usually the physiotherapy, and the most important thing is we do not want the saliva to be going into the larynx. So these people will have aspiration problems initially, but slowly as the compensation occurs, they get back their voice, and at the same time the glottis, once it closes, the aspiration problems also come down. So recurrent laryngeal nerve injury, if it is, it may be a neuropraxia which can recover, or if there is a recurrent laryngeal nerve injury, then there can be a compensation that occurs. So the patient will have almost near normal voice, and the laryngeal function is also preserved. That is as far as the recurrent laryngeal nerve unilateral is concerned. Now, if there is a bilateral recurrent laryngeal nerve injury, both the vocal cords are in the paramedian position. So they will be able to speak all right, because there is the vocal cords are together, whether there is some kind of a breathy voice. But the other important thing is, when you inhale, the abduction doesn't take place, and so the air has to pass through this narrow passage, and so that produces a constriction and produces what is known as stridor. Stridor is nothing but noisy breathing. Okay, so the vocal cords are in the paramedian position; they're fixed there, and the speech is to some extent compromised. But the most important thing that we need to consider is the air passage. So there is the passage is narrow, and because the abductors, the muscles which open up the larynx, do not function, as the air passes through this narrow passage, produces sound which is called stridor. So the problem with this recurrent laryngeal nerve, both sides involvement, is the breathing problem, the stridor. So that needs to be attended to, and then the various tests that are being done in order to evaluate when there is a vocal cord palsy, the superior laryngeal palsy, recurrent laryngeal palsy, how the vocal cords come to the center, and then there is in one side recurrent laryngeal nerve, the vocal cord is in the cadaveric position, and then initially the paramedian and then cadaveric position, and so the aspiration problems occur. If they keep continuing to have these aspiration problems, basically because that is the one which can lead to the pneumonias, aspiration pneumonias, and people may have severe infection and may die of these recurrent chest infections. So they would require some kind of a help in the process and in the way of the surgical closure or reduction in the size of the glottis region. Now, physically, you need to evaluate whether two functions. One is the voice production, which is secondary, not very important. The first one is the aspiration. So, if the patients are aspirating and they have a poor, good voice, not advisable. So, let us try to see what are the tests that are being done in order to see that the voice is regained. At the same time, the stridor, the air passage, and the protection to the lower respiratory tract is maintained. These are the two things that we need to consider. Now, the evaluation unilateral paralysis, there is a simple test where there is a vocal cord palsy on one side. Ask the patient to phonate, and you just compress on the side where there is a paralysis, and this vocal cord is pushed medially, and so there is good approximation of the vocal cord and the voice becomes better. So in such conditions, we can do a procedure called medialization of the vocal cord, the paralyzed vocal cord. The various procedures that are described. One is the injection of the Teflon paste, the fat, the collagen, the hyaluronic acid, calcium hydroxyapatite gel, and these are the various things that can be injected into the vocal cord proper, so that there is a medialization of the vocal cord, and the vocal cord from the opposite side comes and opposes clearly, producing a good voice. At the same time, you should not compromise on the air passage. If you inject more, there is always a chance that the vocal cord gets into the midline and the patient goes into stridor. So injection technique is various. Endoscopically it can be done, or there is another, this is what the injection procedure, okay? Endoscopically or percutaneously also it can be done. So this is from the outside, and this is the vocal cord. This white thing is the vocal cord and paralyzed vocal cord, and so this is injected into this, so that this vocal cord comes very close, and then the gap is reduced so that speech is improved. So this is the diagram. Then that is one procedure. There is another procedure which is called thyroplasty. Thyroplasty in the sense from the thyroid cartilage you open up and then make a slit into the thyroid cartilage and push the and you go you don't you keep the internal pericardium intact, and so you make a small window there and then push the vocal cord, paralyzed vocal cord medially. Push the vocal cord medially so that when speaking, the other vocal cord comes and approximates and gives rise to a good voice. So these are the procedures: medialization, thyroplasty, or type 1 thyroplasty. Then managing the bilateral abductor paralysis. That means vocal cords are in adduction and there is a compromise for the air passage. There is a compromise if the patient is in stridor, is not able to take good breath, and so it goes into hypoxias. So in such patients, we have to preserve the passage, the air passage, and for that there are several procedures that are being described. One is the arytenoidectomy, the Woodman suggested. The arytenoidectomy, where the arytenoid which is sitting on the lamina of the cricoid, and that is the one. And the cordotomy, that is making a cut into the into the vocal cord and freeing it by laser procedures. Okay, by laser. And these are the procedures which are usually done for young people who have good pulmonary reserve. Otherwise, the best gold standard is the tracheostomy. You do a tracheostomy below the in the trachea, and so breathing is so easy. And for this tracheostomy, you just apply a speaking valve. So whenever the patient wants to breathe, you just have to block that air passage, and the air passes through the larynx and so produces the sound. So tracheostomy with a speaking valve is the answer for people, elderly people who cannot withstand these kind of surgeries, because there is always aspiration problem in such patients. So this is what is the bilateral abductor paralysis, the management, and sometimes apart from this, there are some procedures where you can lateralize the vocal cord by the stitches, and then the air passage is open. Air passage has to be adequately open. Okay? So you can compromise here with the speech. Okay? Usually that is what happens. So now, laryngeal nerve innervation is slowly gaining popularity now, because the ansa cervicalis, that is the called hypoglossal nerve, and then it gives rise to the ansa hypoglossi, supply the strap muscles. So this ansa hypoglossi is sutured onto the recurrent laryngeal nerve. It might, and they found that sometimes the vocal fold, the glottic closure is good, and the vocal fold edge straightening also happens. So this is as far as the laryngeal nerve innervation, the ansa hypoglossi being stitched to the recurrent laryngeal nerve in cases of injury to the recurrent laryngeal nerve. These are the procedures, and ultimately we should remember that the main function of the larynx has to be preserved, that is prevention of the aspiration. Secondary function, if it can be regained, is the best option. But you should never compromise on the primary laryngeal function, that is the aspiration, because pneumonias are ones which can repeatedly damage the lung, and people may die with the recurrent pneumonias. So this is in brief about the larynx, and to sum up, the vagus is the nerve with its 3 nuclei: tractus solitarius, the dorsal nucleus ambiguus, the motor, the parasympathetic, and the sensory, and how it is coming from the medulla oblongata, coming out posterior cranial fossa through the jugular foramina, and from the jugular foramina it comes into the base skull and then into the neck, and how in the neck, in the thorax, how it comes back into the neck, recurrent laryngeal nerve, and how in the neck it divides into, it gives rise to the nerves which supply the pharynx, the larynx, and the palatal muscles, and how the parasympathetic fibers outflow right from the into the bronchial smooth muscles, the esophagus, and then down into the stomach, the small intestine and large intestine, and as I told you, the longest the cranial nerve is this vagus nerve, and how the larynx, the adductors and the abductors and how the posterior cricoarytenoid is the only abductor muscle, whereas the lateral cricoarytenoid and the posterior arytenoids, how they block the vocal cords, make them come together, and powerful adductors are the ones which prevent the aspiration, and the main functions of the larynx, and the various lesions that occur in the intracranium and at the jugular foraminal level, then the neck and the chest, and how they are diagnosed, the various investigative procedures, the endoscopes, and how we have to tackle each of them, trying to give a good voice, at the same time not compromising on the primary function of the larynx. Just go through this video once again. If you have any doubts, when you come back to the college, you can clear the doubts. Thank you.